If we could look inside the artery walls or the vasculature of every person out there walking around today, would there be anybody out there who has no detectable sign of atherosclerosis? The answer is basically no, at least for people who are at young adulthood and beyond. We know from postmortem studies that just about everybody out there beyond the age of about 20 has some detectable sign of atherosclerosis, beginning with what we would call fatty streaks. Fortunately, we live in a time where heart and vascular disease can be meaningfully slowed. So in today's video, we'll talk about what I would consider to be some of the highest yield testing that most people should probably know about if the interest is adding healthy years of life by slowing heart and vascular disease. Many of the tests that we'll go over are available at routine clinical visits, but importantly, many are not, although they are still important and useful. As always, none of the following is medical advice. Please always consult your doctor before making any health decisions. And with that, let's jump into it. So the first test that we'll talk about is called ApoB. So ApoB is a prime driver of atherosclerosis or plaque formation within the artery walls, and it sits on top of LDL particles and related particles, commonly known as bad cholesterol. So plaque formation begins when ApoB carrying particles start to invade the inner layer of the artery wall called the endothelium. The rate at which ApoB containing particles can cross over that endothelium and invade the arterial wall depends upon endothelial permeability. We'll talk about that a bit later. Once those ApoB containing particles invade the artery wall, the content that they carry, like the lipids, get modified by getting oxidized and glycated. That triggers an immune or inflammatory cascade that causes immune cells to come and also join up and invade the artery wall, like macrophages, which then ingest that lipid content and become foam cells. Now, LDL cholesterol is a very important marker of heart and vascular disease. But why are we talking about ApoB? The reason why is that LDL, commonly performed at routine clinic visits, is LDL-C. And what it's measuring is the mass per unit volume of LDL cholesterol. Conversely, ApoB is looking at particle count per unit volume. Now, where things can go wrong in terms of estimating someone's heart and vascular disease risk is when there's a discordance between LDL-C and ApoB. And for that reason, ApoB tends to be a better marker. These would be things like metabolic dysfunction, like diabetes and obesity, where someone has a lot more small, dense LDL particles that would raise up the ApoB count, but it wouldn't necessarily be reflected in the LDL-C metric. So in other words, that LDL-C metric that's typically attained at routine clinical visits would potentially underestimate someone's risk of heart and vascular disease. That brings us to our next test, which is Lp(a) or lipoprotein A. So Lp(a) is a subtype of LDL particle that's particularly problematic. And in most people, it's normal. But in some people who have genetic variations, Lp(a) can be high or even much higher. So for that reason, many of the European guidelines recommend obtaining at least one measurement of Lp(a) throughout someone's life, since the level tends to be genetically determined. Why is it that Lp(a) is so problematic when it's high? It's because it's an LDL particle that has a side chain that looks like a ribbon. And that side chain can accelerate plaque formation because it's sticky and it sticks to the endothelial wall and accelerates plaque formation. Now, the bad news is that there's not a lot of behavioral or lifestyle things that you can do to modify the level of Lp(a). There are some drugs that have shown some efficacy in lowering Lp(a), but right now nothing out there is routinely used. These would be things like the PCSK9 inhibitors. There's also some clinical trials going on with nucleotide-based therapies that can drop Lp(a) down by about 95%. On the positive side, we do know from published research that if someone optimizes their non-Lp(a) risk factors for heart and vascular disease, that they can achieve very meaningful risk reductions. The EPIC Norfolk study, looking at about 14,000 patients, showed that even individuals with Lp(a) above 50 were able to achieve very meaningful risk reductions in their risk of heart and vascular disease. Those risk factors included things like not smoking, not having diabetes, having a healthy body composition, healthy diet, and exercise. Our next test is hs-CRP. So hs-CRP means high sensitivity C-reactive protein. The C-reactive protein is an inflammatory marker that's not necessarily specific to heart and vascular disease, but it generally means that there's something inflammatory going on somewhere in the body. In 2019, the American College of Cardiology put out a threshold of 2 milligrams per liter or greater as being predictive of heart and vascular disease. We also know that levels above 2.1 double the risk of stroke and triple the risk of heart attack. Now, it is important to consider that correlation does not equal causation, but we do know from clinical trials that modulating the inflammatory cascade can lower someone's heart disease risk. That brings us to our next marker or test, which is GlycA. So GlycA is a composite marker of acute phase reactants that relate to inflammation, and it's more stable over time than hs-CRP. Basically, GlycA is looking at the modified end products of what are called acute phase reactants. These are things that the body produces when there's inflammation going on. And importantly, GlycA in some of the statistical models has been able to account for the residual variation in heart disease risk, even after including things like blood lipids and lifestyle. Now, for our next group of tests, we've touched on these in other videos, so we'll go over them briefly here. But those tests would be triglycerides and HDL. So these two are related because HDL is a really important type of particle that cleans up the cholesterol within existing plaques in the artery wall and then brings that cholesterol back to the liver. The problem is that when triglycerides are high, HDL gets worse at doing its job and there's not as much of it around, at least not for as long. The way that triglycerides become high is that the liver has to ship them out due usually to things like insulin resistance and excess nutrition or excess macronutrient consumption like fructose, and it packages those triglycerides into a container called a VLDL. Now the VLDLs get shipped out from the liver. They have to get rid of some of those triglycerides. So what they do is they offload them to other particles, HDL being one of those particles, in exchange for a cholesterol ester back from HDL particles. That creates dysfunctional HDL particles that are not as good at reverse cholesterol transport and that also don't live for as long in the system. And so what ends up happening is that when you have high triglycerides, that drops your level of HDL, which means that the cleanup of cholesterol in the artery wall is impaired. And generally there's no universal consensus on what the optimal triglyceride to HDL ratio is. 2 to 1 is a common reference, but 1.5 to 1 or lower is what I tend to go with, noting that it is possible to have too low of a ratio. The next test that we'll go over for cardiovascular prevention is the omega-3 to omega-6 ratio. This reflects the ratio of omega-3 to omega-6 fatty acids on the membranes of red blood cells. Specifically, we know that people with an omega-3 to omega-6 ratio of less than 4% are at higher risk of cardiovascular disease. Higher omega-3 levels, on the other hand, have been associated with lower inflammation, lower risk of sudden cardiac death, and better endothelial function. So typically the range that's targeted for an optimal omega-3 to omega-6 ratio is about 8 to 10 or 8 to 12%. Now, an important caveat about supplementing with omega-3s, we know from multiple different randomized controlled trials and a meta-analysis of randomized controlled trials that supplementation with omega-3s is associated with a higher risk of atrial fibrillation. And from my read on the literature, I think this is a very real risk. That risk has to be weighed against the risk of other conditions like heart disease and stroke. So it's something that's important to discuss with the doctor before you go and supplement with omega-3. It's something to be aware of. Now, our next test is not going to be much of a surprise, but it's actually really important. We talked about how the rate of ApoB carrying particles, those atherogenic particles that cause plaque formation, the rate of those traversing and invading the arterial wall is directly proportional to the permeability of that thin layer on the wall called the endothelium. Well, blood pressure is our next test. And the reason why blood pressure is so important for this purpose is that as blood flows through the arteries and the blood vessels, it has to go around turns and branch points. And particularly at those points in the vascular systems, there can be higher flow, which causes shear stress and mechanical stress along the artery wall or the endothelium. That can cause endothelial damage and stress, leading to increased permeability and allowing those particles to get in and invade the arterial wall. So having an optimal blood pressure is incredibly important for long-term prevention of heart attack and stroke. Now, lots of different life scenarios can cause blood pressure to go up or down. Things like lack of sleep, acute stress, chronic stress, different dietary patterns, exercise, lack of exercise, metabolic dysfunction, they all can cause fluctuations in blood pressure. So something that's important to do is to take repeated measurements of blood pressure over time. A good way to do this is to go out and buy a blood pressure cuff, log it daily, keep track of it over weeks, And bringing that to your physician can help them to make a good decision with you about the best way to get blood pressure to an optimal range to minimize long-term risk. Now, lastly, our talk on cardiovascular prevention tests wouldn't be complete unless I mentioned these two tests as honorable mentions. The first one is homocysteine. So elevated levels of homocysteine, which is related to the metabolism of methionine, have been associated with increased risk of heart attack. However, efforts to lower homocysteine levels as a therapeutic intervention in the literature have been sort of here and there. Homocysteine, for that reason, could be important in some people as a risk indicator of how aggressive someone needs to be with their cardiovascular prevention. But in terms of RCTs supporting lowering homocysteine as an intervention to prevent future heart disease, the results I would say at this time are not particularly strong. The next test is a coronary calcium score, or coronary artery calcium score. It's a CT scan of the chest that basically picks up on calcifications that are deposited within the walls of the arteries that supply the hearts, called the coronary arteries. Now, this could be useful depending upon someone's situation. I tend not to lean particularly heavy on the data that this shows unless it's particularly severe. The reason why is that the coronary calcium score picks up on calcified plaques. And those happen to be the ones that are more stable, meaning that they're less likely to break off and float downstream and cause a heart attack. The plaques that cause a bit more concern are soft plaques, which don't show up on a coronary calcium score. Those are the ones that are more at risk of breaking off, floating downstream, and creating a clotting cascade. In addition, certain drugs act actually by stabilizing plaque, like statins, which accelerate the calcification of plaques. So in those cases, someone's coronary calcium score would come back higher than expected, but it's also possible that if someone has a lot of soft plaque and not much calcified plaque, the score could come back as an underestimate of someone's real risk. With that, thank you so much for listening. If you want to support this channel, the very best way to do that is to hit the subscribe button and the like button. If you're on Spotify and are able to head over and leave a review, it helps the channel to be able to reach more people. So with that, thanks again, and we'll see you next time.